So first of all, when we discuss MZL, we cannot discuss this as a whole group because there are three sub-entities, three different diseases. Extranodal marginal zone lymphoma that in the United States account for 61%, nodal marginal zone lymphoma that accounts for 30%, and splenic marginal zone lymphoma that accounts for 9%. And treatments are quite different. I will start with nodular marginal zone lymphoma. In nodular marginal zone lymphoma, usually criteria for treatment and the treatments are identical, currently at least, for follicular lymphoma. So if the patient needs therapy, the treatment usually is BR, bendamustine, rituximab, but some patients really don't need therapy, and we may go with wait and watch. In extranodal marginal zone lymphoma, here we will divide them based on stage. Patients that present with stage 1 disease can be cured. It's not curable disease, but can be cured with radiation. So one of the best approaches is to use radiation to the involved organ. Not to every organ we can use radiation. We usually don't like to use it to parotid gland because of dryness and so on. But to the eye, we can use it with reasonable toxicity. And that's the best approach for stage 1. In patients with advanced stage disease, once again, depends on clinical presentation. Some patients may not need immediately therapy and may be followed without therapy on wait and watch, and eventually will need therapy and then will be treated. But patients that need therapy, currently the best approach is bendamustine rituximab. SOLAIRE study that was published and follow-up updated in blood demonstrated overall response on 100% and complete response more than 90% with duration of response more than 5 years. And for splenic marginal zone lymphoma, once again, not everyone needs treatment. Approximately 30% don't need treatment. 70% will need treatment. Currently, the best approach would be rituximab to start. Splenectomy that was used previously, we don't use it almost never nowadays for upfront therapy. In some cases, you may need to use BR, but based on the data in the literature, it is associated with increased infections. So currently, we're using rituximab. I want to make a general comment. In all of these cases that we discuss, you need to make sure that we are not treating patients with transformation that we may not see in the biopsy that we did, because it depends from where you're doing biopsy, because in reality, many patients in marginal lymphoma that are treated with BR progress very fast within the first year, and when we biopsy them, we have transformation.